All right. Well, good morning, everyone. Hope you all are doing well. If you don't mind going ahead and opening up your chat box, we're going to get started in just a little bit. If you don't mind opening up your chat box, saying hello and where you are logging in from, super excited to get started shortly with our review. Hello, everyone. Hey, Subhav, Stanley, Shanice, Aisa, Akshita, Yoshida. Wow, wonderful, wonderful. And if you'd like, you can go ahead and turn your chat box feature to everyone so that then you can stay active and engaged throughout the whole session and also go through some of the key concepts with each other. So it kind of gives that community feel. All right. Very nice. We'll get started in just a little bit. I see people from Chicago, Sarasota, India, Miami, North Carolina, Philadelphia, Ecuador. This is amazing. International audience. And if you're joining us on YouTube, please make sure you are also engaging in the chat box. Just a quick reminder to everyone, I put it in the Zoom link as well. However, today is going to be a preview session for our upcoming surgery review. So in the next couple of minutes, I will be talking a little bit about the surgery review, but I did put it in the chat box for you all to look at. I did create a small curriculum. The surgery review will be held next week. It is a 2-day paid webinar. It is a rapid review course for just a limited amount of students who are preparing primarily for surgery shelf and are in the Step 2 CK dedicated study mode. So feel free to check that out. And we'll get started in just about a minute. Want to make sure everybody on YouTube is good. Excellent. Great. Just as we get started, if you don't mind letting me know if you can hear me, see me, and also see my slides, do you mind just saying yes into the chat box, please? Awesome. Wonderful. All right, great. And I'll answer some questions in the live Q&A at the end of the session, but why don't we go ahead and get started? Today, we are going to be covering a very important topic for Shelf and Step 2 CK, and that is related to neurology. Now, neurology questions can be embedded in pediatrics and internal medicine, but we are going to really take a deep dive into the key concepts tested by NBME and USMLE when it comes to neurology. As I mentioned before, this is going to be a preview session to my upcoming comprehensive rapid review for surgery. It is going to be held next weekend, Saturday and Sunday. I will be providing details to you all at the end of the webinar, but I did put in the sample links right here so you all can consider signing up. If you do attend my surgery shelf review next weekend, I will be also providing you exclusive complimentary access to my Step 2 CK rapid review course. If you have not yet joined this course, it is jam-packed with high-yield material. It collates all of the key vignettes that you need to know for each of the shelves, and I put in a 6-hour section going through test-taking strategies for shelf and Step 2 CK. Without further ado, I do want to respect you all in terms of, coming here, showing up. I really appreciate it. If you guys are ready to go ahead and get started, go ahead and type in yes into the chat box. All right. Well, one of the things that I just want to emphasize is that I ask for an hour and 15 minutes of your time. Please cut out the distractions, close out any of the tabs. I have intentionally made this review focused on active recall, integrating vignettes, You don't want to miss any of these concepts. So I would encourage you to cut out distractions, stay focused with me, and keep the chat box open so that you can continue to answer and stay on the edge of your seats when it comes to these questions. For many of you, this may be your first webinar. However, if you have attended many webinars in the past, I want to just briefly introduce myself. My name is Rahul. I'm a practicing pediatric critical care physician, and I'm very passionate about medical education, particularly preparing students for Step 1 and Step 2 CK. For Step 2 CK, I use a lens of clinical reasoning, and my goal is not only that you get a kick-ass score on your exam, but I want to prepare you to be a damn good resident. And that's where these reviews are going to be so solid as you progress through your medical journey. I think what makes HyGuru very unique is that I focus on these 4 fundamental principles: vignette-focused learning, integration amongst organ systems, test-taking strategy, and as you can see, the energy coming across to your study space right now, I focus on making sure that you have a peak mindset, because on exam day, that's what's going to make or break it. The triad that I use when I work with students one-on-one is I go through content integration and clinical reasoning, especially for shelf and Step 2 CK. I focus a lot on next best step in management, diagnostics, as well as pharmacological and surgical aspects of management. Again, I like to focus on the test-taking psychology and also how to be productive on a day-to-day basis throughout dedicated study. I think most importantly, and I'm so humbled, I mean, we have 220 people joining us right now, and you are a part of it. HyGuru has just become a big family. And I really just appreciate your guys' support. Many of you support me on Instagram or Reddit or any of these social media platforms. I really love to connect with bright students like you. So please reach out. I'm happy to help throughout your journey. One of the things I'm super proud of is taking that personalized approach. And this is just a few of the students who I've worked with that have received great success in the past year or so. I do want to cover how Step 2 is different than Step 1. I think what's key in Step 2 is that Step 2 focuses on a lot of diagnosis, risk factors, and management questions. One of the things you'll notice is when it comes to diagnosis, it is all about isolating what is that vocab word. And when it comes to understanding a diagnosis, in my opinion, you have to understand the pathophysiology. And the Step 2 CK really plays on the basic science in order for you to understand what's the diagnosis, what's the next best step in management. So say, for example, you get in a vignette, a patient is going to have impaired consciousness. They're going to have shaking of the upper and lower extremities. And then afterwards, they're going to have confusion. What does this sound like? Go ahead and type that into the chat. What does this sound like? What does this mini vignette sound like? Excellent. Many of you are saying seizure. Well, you know, the USMLE really wants you to understand what's the pathophysiology of why that's happening. Is there going to be a metabolic cause? Is there going to be a structural etiology, a vascular etiology? And all of these are causing what pathophysiology? Abnormal discharge of electrical activity. And you are getting that seizure because of some underlying cause that is causing this multifocal abnormal discharge throughout the brain. What you want to understand here is that next best step is either assessing the underlying pathophysiology or reversing the underlying pathophysiology. How do you assess underlying pathophysiology? Well, hey, get a blood sugar, put an EEG on, do a non-contrast head CT followed by an MRI. If there's a fever and altered mental status, consider LP. I'm just taking pictures of what I think is the pathophysiology going on within the patient. And the next best step is to reverse the pathophysiology. For example, if the patient is hypoglycemic, give dextrose boluses. If the patient is having status epilepticus or a seizure lasting greater than 5 minutes, go ahead and administer a benzodiazepine, because increasing GABA is going to decrease the chaotic firing. So I just want to emphasize that when it comes to Step 2 CK, learn it from a pathophysiology lens and then integrate the diagnostics and the pharmacological agents. So I did mention what is a diagnosis. And a diagnosis, in my opinion, is a vocab word that is linked to an underlying pathophysiologic mechanism. So let's go through this neuropathological mechanism. Infectious trigger that leads to a humoral antibody response. That then causes autoimmune destruction of Schwann cells, which myelinate the PNS. And then you get axonal degeneration of peripheral, motor, and sensory fibers. What is going to be the vocab word that encompasses this pathophysiologic mechanism? Go ahead and type that into the chat. Good. Many of you are saying Guillain-Barré syndrome, which is going to be a demyelinating polyneuropathy, and you're absolutely correct. So as you can see, if you understand the story, which is pathophysiologic mechanism, you just have to understand or integrate the vocab word, and bam, there you get your diagnosis. But what is very important is that management, again, assesses or reverses the underlying pathophysiology. So how I'm going to build on what we just went through is, the humoral antibody response, that's why on lumbar puncture, we get the albuminocytologic dissociation, where we get elevated protein levels, but a normal total cell count in the CSF. Oh, wow. If we have ascending axonal degeneration of the peripheral nerves, no wonder that EMG shows decreased nerve conduction velocity. What about management? Well, remember, we want to reverse Guillain-Barré, which is autoimmune mediated. Take the bad autoantibodies out, i.e. plasmapheresis. Bind up those autoantibodies, intravenous immunoglobulin. And finally, assess the FVC. And why is that? Because if you get ascending paralysis, you may disrupt diaphragmatic function, and the patient may have acute respiratory failure that you will have to act on, especially if they have very negative, or if they have an inability to generate a negative inspiratory force, or they have reduced vital capacity. Now, for any test question related to neurology, my thought process is threefold. First off, I like to say that any focal neurological deficit, I say the S word, shit, it's a stroke. The other thing that I pay attention to in neurology questions is difference between upper motor neuron and lower motor neuron sign. Go ahead and type into the chat, what is an example of an upper motor neuron sign? Excellent. Many of you are saying hypertonia, hyperreflexia, Babinski, spasticity. Absolutely. And you want to contrast that with lower motor neuron signs, which everything is basically going to be slowed down. Hyporeflexia, you're going to get atrophy, muscle fasciculation, hypotonia. So pay attention. In neurology questions, you want to pay attention to the physical exam. Now, when it comes to stroke, we're going to be talking a little bit about the different types of stroke: hemorrhagic, thrombotic, and ischemic strokes. We're going to be talking about how there's a three-step process for strokes, where we're going to be integrating the contralateral innervation, the fact that large vessel strokes have both sensory and motor paresis, and we're going to be talking about the homunculus, where the inner part of the homunculus is all going to be your lower extremities and trunk, whereas the outer portion of your homunculus is going to be face and upper extremities. We also are going to continue to emphasize that neurology questions, you want to pay attention to the physical exam, because then you can quickly stratify, am I dealing with upper motor neuron, lower motor neuron, or both, and isolate where is the deficit. Let's go ahead and go through our first question. A 48-year-old man presents with progressive weight loss due to difficulty swallowing. The patient has muscle stiffness in the morning, and his wife has noticed excessive wasting of his arm and calf muscles. The patient has intact bowel and bladder function. Examination is notable for fasciculations of the lower extremities. He has an asymmetric uvula. Upper extremity exam is notable for spasticity. Which of the following is the most likely diagnosis? A, ALS. B, myasthenia gravis. C, Lambert-Eaton syndrome. D, dermatomyositis. E, acute HIV, or F, rheumatoid arthritis. Go ahead and type your answer into the chat box. Excellent. Many of you are isolating the fact that we have a lower motor neuron issue right here, and we have an upper motor neuron issue here. Whenever you see lower motor neuron plus upper motor neuron, you want to be thinking about amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. Very good. All right, so today what we are going to be covering are a few high-yield topics, but we're going to go deep into these topics because there are many USMLE and NBME questions that come up related to these topics. We're going to be talking about neuromuscular disorders. We're going to be talking about stroke, multiple sclerosis, delirium, and spinal cord disorders. Before we get started, I just want to check in. Are you guys staying active and engaged? Go ahead and type in yes into the chat box. I have a couple of friends who make fun of me when I say that, but I want to make sure that there is some good vibes and good energy here. All right, very good. Let's go ahead and go through this question together. A 5-year-old boy is brought to the pediatrician for a routine checkup. The mother expresses concern about her son's difficulty keeping up with his peers during play. When you see this, you should be thinking about a couple things. You should be thinking about neuromuscular junction disorder, cardiac disorder, say dilated cardiomyopathy, or you should be thinking about a lung issue, say, for example, like asthma. She notes that he has a peculiar way of getting up from the ground, using his hands to push off his knees. Physical exam shows enlargement of the calf muscles. Which of the following findings is most likely associated with this condition? A, increased serum creatinine kinase levels. Sorry about the typo there. Kinase levels. Elevated ALT levels. Positive dystrophin staining on muscle biopsy. Or D, normal nerve conduction velocities. What do you think is the best answer here? Excellent. If you are saying A, you are absolutely correct. Again, this is going to be your Duchenne's muscular dystrophy. Key things for you to know is you get the calf pseudohypertrophy, which is going to be here. You're also going to get that Gower's sign, which is important. Remember that this is going to be a fibrofatty replacement of the muscle. So you're going to have evidence of muscle damage, which is what the elevated CK is. And because this is going to be a frame shift mutation, sometimes even a nonsense mutation, you actually will get absence of dystrophin on your muscle biopsy because of the fibrofatty replacement and the protein is just not there. All right, so what we're going to be doing is we are going to be creating a framework on how to approach neuromuscular disease questions on shelf and your step 2 CK. I want to orient you by just going through normal gross neuroanatomy. Here you are going to have the peripheral nerve emanating from the spinal cord. The spinal cord, in particular, the lower motor neuron, is going to send out a dendrite or an axon that is going to be known as the peripheral nerve. That peripheral nerve is going to innervate a fascicle of muscle fibers. And then subsequently, if we zoom in this region right here, kind of create a magnifying glass, we are going to be seeing the neuromuscular junction. Now, one of the key things that I want to emphasize here is the fact that pathologies can link in these different areas. For example, if you're going to be talking about spinal cord disorders, you can be integrating B12 deficiency, ALS, which we talked about, and Tabes dorsalis. Recall that when it comes to B12 deficiency, I'm going to make the lesions in blue. You're going to have issues with corticospinal tract and the dorsal column medial lemniscus system. So that's going to be B12 deficiency. Whereas tertiary syphilis or Tabes dorsalis, I'm going to do in red, you are going to have the dorsal root ganglia that is going to be affected, as well as the dorsal column medial lemniscus. So those patients are going to have issues in your vignette with proprioception, vibration sense, etc. What about other areas that we can integrate here? The peripheral nerve axon. Peripheral nerve axon, you're going to be thinking about Guillain-Barré as well as diabetic neuropathy. Understanding the fact that diabetic neuropathy, this is going to be a patient who has long-standing diabetes. These patients are also going to have very elevated hemoglobin A1C. They're going to have foot ulcers or bad wound healing. They could even get something known as a Charcot joint, where you are not going to see good delineations with your tarsal bones. Remember, the mechanism for diabetic neuropathy is going to be non-enzymatic glycosylation of these peripheral nerves. Muscle disorders are also going to be integrated here. We're going to be thinking about Duchenne's muscular dystrophy, which we talked about, rhabdomyolysis. This could be due to many different things like strenuous exercise. You're going to be thinking about hypothyroidism. Even statins can cause you to have some myopathy and rhabdomyolysis. What do you think is going to be a key lab finding when we're thinking about rhabdomyolysis? Go ahead and type that into the chat. Key lab finding for rhabdomyolysis. Excellent. And I want everybody to stay active and engaged. If you're saying increased CK or myoglobinuria, you're absolutely correct. Myositis is going to be inflammation of the muscles. You can get dermatomyositis, which has the rash, and polymyositis. And we're going to be talking about those. But remember, they are under the category of inflammatory muscle disorders. When it comes to the neuromuscular junction, you want to break it down into presynaptic pathologies, intrasynapse pathologies, and postsynaptic pathologies. So presynaptic pathologies, we're going to be thinking about Guillain-Barré syndrome. You're going to be thinking about inhibition of snare protein fusion, which is what botulism classically does. Tetanus is also going to be a presynaptic issue. Intrasynaptic, you're going to be talking about your organophosphate poisoning. Typically, this is going to be at a farm or at the back of a shed. And will these patients be wet, 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 or dry, dry, dry? What do you think? In your vignette, will these patients be wet, 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 or dry, dry, dry with organophosphate poisoning? Good, exactly. If you're going to be inhibiting acetylcholinesterase, you're going to have an increased amounts of acetylcholine, and that's going to bind to muscarinic receptors, causing you to have glandular activation. At the postsynaptic level, you're going to be thinking about myasthenia gravis. And what's key for us to know with myasthenia gravis is that these are antibodies against the nicotinic acetylcholine receptor. You also want to understand that the next best step is to get a chest x-ray or a CT scan, because myasthenia gravis is going to be associated with thymomas. All right, so with this framework, what we're going to do is we're going to apply these different scenarios. What is the likely underlying etiology of his weakness? A 68-year-old male with history of COPD presents with progressive weight loss, hemoptysis, cough, and weakness. He has had a 30-pack year smoking history as well as hypertension. Exam shows generalized proximal muscle weakness and loss of deep tendon reflexes in the lower extremity. What is the likely etiology underlying his weakness? What do you think is the most likely diagnosis here? Wonderful. If you're saying Guillain-Barré syndrome, you're absolutely correct. In a patient with long-standing smoking, if you see these constitutional symptoms, you have to be thinking about lung carcinoma. Another thing for us to recognize is that lung cancer plus weakness, that really should activate the illness script that you're dealing with a paraneoplastic syndrome related to small cell lung cancer, which is Guillain-Barré myasthenic syndrome. That's the whole diagnosis name. And this is going to be autoantibodies to the presynaptic voltage-gated calcium channels. As you are going to get more inhibition of these voltage-gated calcium channels, you are going to get weakness. However, if you keep stimulating the axon, i.e., you keep repetitively contracting the muscle, you actually are going to get weakness that is going to improve with activity. And I think that that is super important, that this is going to be an incremental response. So we're going to just go ahead and review some key neuromuscular junction disorders. Guillain-Barré myasthenic syndrome. This is going to be autoantibodies to voltage-gated calcium channels. The USMLE vignette that you want to keep in mind is chronic progressive proximal muscle weakness in a smoker who has constitutional symptoms. And that's how I even like to take UWorld notes. Tempo, chief complaint, demographic factors. Myasthenia gravis is going to be at the postsynaptic receptor. It is autoantibodies to the nicotinic, which is an ion channel receptor. You're going to see in your vignette chronic, progressive diplopia and dysphagia, indicating that you are going to have cranial nerve or bulbar symptoms. You're going to have weakness that is going to be worse at the end of the day. And this patient may have a new onset mediastinal mass, which is going to be very characteristic of the thymoma. Remember that acetylcholinesterase inhibitors improves the symptoms. And what it does is it increases the amount of acetylcholine in the neuromuscular junction. I just want to kind of go through a random integration here, but I think it's going to be very helpful. So let's go ahead and go to the whiteboard for just a second. I want to really make this link between Guillain-Barré and myasthenia gravis with osteoarthritis and rheumatoid arthritis. What's super cool here is that Guillain-Barré syndrome, you are going to get muscle weakness that is going to improve with activity. On the other hand, if you think about rheumatoid arthritis, joint stiffness that is going to improve at end of day. Remember that the key illness script related to rheumatoid arthritis is the fact that these patients are going to have prolonged morning stiffness. Myasthenia gravis, you're going to have muscle weakness that is going to worsen with activity because you ran out of packets of acetylcholine, and at the postsynaptic junction, the autoantibodies against the nicotinic receptor are going to be winning and causing you to have weakness. Whereas osteoarthritis is joint pain and stiffness worse at the end of the day because it's all wear and tear. Okay. So these are some quick associations, but I do think that they will help you as you continue to study for different shelves as well as step 2. All right. Very good. Myositis disorders is going to be another key neuromuscular junction pathology that we have to integrate. Remember that this is going to be related to autoimmune inflammation of muscle leading to breakdown. You're going to get chronic, symmetric, proximal muscle weakness in a middle-aged female. This middle-aged female may have some stigmata in the vignette of other autoimmune etiologies, such as, for example, Raynaud syndrome. Maybe they have a history of adrenal insufficiency or Hashimoto's thyroiditis. Remember that this is going to be an inflammatory muscle condition, so you are going to have an elevation in CK as well as non-specific markers such as ESR and CRP. And recall that dermatomyositis, key things is that you are going to have the heliotrope rash, which is going to be around the eyes, and the Gauthron's papules, which are going to be on the knuckles. This is going to be indicating that there is perimesial T cell infiltration, and thus you are going to get a rash related to the inflammation of the muscle. The other thing to really understand is that dermatomyositis, similar to acanthosis nigricans, is associated with visceral malignancy. So one of the next best steps in management is to consider getting an MRI or a CT of the chest, abdomen, and pelvis, because once you see dermatomyositis, you're worried for an underlying malignancy. All right. Polymyositis and polymyalgia rheumatica sometimes confuses me when it comes to vignettes. So I wanted to just separate these for you all as well. When it comes to polymyositis, it is endomesial inflammation by CD8 positive T cells. Remember that if it's perimesial inflammation, that's going to be your dermatomyositis. You're going to get in polymyositis proximal muscle weakness, and we talked about elevations in CK. Other things that are going to be a little bit more specific for polymyositis is going to be your Jo1 antibodies, which are going to be against tRNA synthetase. You're going to be thinking about your anti-SRP antibodies. as well as anti-MI2 or MI2, which is going to be against helicase. Remember, helicase is what's going to be important in the replication fork during DNA replication. Polymyalgia rheumatica is going to be an autoimmune granulomatous inflammation of joints, but especially large and medium-sized arteries. In particular, polymyalgia rheumatica, make a star right here. It is going to be associated with temporal giant cell arteritis. Now, polymyalgia rheumatica, in the vignette, you're not going to get proximal muscle weakness. You're going to get proximal joint stiffness. And I can't stress that enough. They're going to say inability to comb the hair because of the stiffness or get up from the chair. Because this is more joint related, your muscle enzymes are actually going to be negative, but you're still going to have your elevations in ESR and CRP. And again, these are non-specific acute phase reactants. Next best step in management with polymyalgia rheumatica, IV methylprednisolone. This is going to be a common theme for derm and rheumatology management. Reduce the inflammation with steroids, and then you want to screen for temporal giant cell arteritis. And if you notice the patient is going to have jaw claudication or a temporal headache, remember the first step in management is to get the steroids on board before going down the route of a temporal artery biopsy. Let's go ahead and go through this question. By the way, you guys enjoying? Yes, no, maybe so? Excellent. We're a little over halfway. You guys are doing wonderful. And if you're tuning in at home after this live recording, I really appreciate you guys staying active and engaged throughout this session. All right, very good. So here we have a 35-year-old female marathon runner who presents to the office with weakness and tea-colored urine 2 days after a 10-kilometer run. She has bilateral thigh weakness, and a urine analysis reveals dark urine with positive heme. Microscopy reveals no red blood cells. Renal function panel is notable for elevated creatinine. Elevation of which of the following laboratory findings would most likely be seen in this patient? A, CK, B, ANA, C, calcium, D, TSH, or E, bicarb? What do you think is the best answer here? Excellent. Many of you have activated the illness script of rhabdomyolysis, and the best answer is going to be elevation in CK. Let's go ahead and just break this down. Remember that this is going to be strenuous activity. The tea-colored urine is going to be associated with myoglobin. The dark urine that is heme positive, but microscopy negative. This indicates the fact that myoglobin and hemoglobin on a UA are just going to test positive. But what's important for us to know is that underneath the microscope, you don't see red blood cells. So this rules out hematuria. Rhabdomyolysis, in particular myoglobin, is toxic to the proximal convoluted tubule. So the elevated creatinine indicates that you have intrarenal AKI. And sometimes you can get the muddy brown cast, i.e., you can get renal tubular necrosis. Lab findings related to rhabdo is going to be CK. Management is going to be ensure hyperhydration and get serial labs, especially supporting the kidney and the muscle function. All right, so what I want to do now is I want to go through a quick pharmacology review. I'm going to be really emphasizing the mechanism of action of the pharmacological agent. Here is one that I forgot to put the transition to on, so let's go ahead and go through this one. Long-acting oral acetylcholinesterase inhibitor for myasthenia gravis, and that is going to be pyridostigmine. I like the mnemonic pyridostigmine gets rid of myasthenia gravis. Pyridostigmine gets rid of myasthenia gravis. Now, some questions also talk a little bit about this ice pack test. This basically is going to be a bedside test that you can use. And if the patient has improvement of the ptosis with this ice pack test, which kind of releases packets of acetylcholine, you're going to then, as your next best step, do a confirmatory nicotinic acetylcholine receptor antibody assay. And again, This is a quick bedside test. The tensilon test or edrophonium test, that it has now kind of fallen out of favor because you can get the specific diagnosis with the antibody test. All right, let's go ahead and go through this question. A patient going to the OR, given an agent that produces sustained depolarization at the neuromuscular junction. What is this pharmacological agent? Go ahead and type that into the chat. Excellent. Sustained depolarization is going to be the nicotinic receptor agonist, which is going to be succinylcholine. It has choline, so it has similar properties to acetylcholine, but what it's going to do is it's going to persistently depolarize the muscle at the neuromuscular junction, and thus you're going to get paralysis. So this is going to be a paralytic agent that we use for OR procedures as well as intubations. What's important for us to know is that succinylcholine can cause us to have even rhabdomyolysis at times, but in particular, malignant hyperthermia. And malignant hyperthermia, the NBME likes to say that the patient is going to have a stiff jaw and increased end-tidal CO2, indicating that there's an underlying acidosis going on, and that acidosis is manifesting as high amount of CO2 returning back to the ventilator. Remember that the next best step in management is stop the anesthetic and provide dantrolene, which is going to inhibit the ryanodine receptor. All right, mechanism of action of cisatracurium. This is going to be a non-depolarizing agent. It is going to be a competitive antagonist at the nicotinic receptor. You're going to reverse this with sugammadex and or neostigmine. Remember that neostigmine is an acetylcholinesterase inhibitor. What is going to be the pharmacotherapy for a patient with Alzheimer's disease? What class of medications are we going to use? Well, that is going to be your acetylcholinesterase inhibitors. Particularly, you're going to be thinking about donepezil, rivastigmine, and galantamine. As you can see, anything stigmine is going to be acetylcholinesterase inhibitor. The very cute mnemonic that I like to use is I am done with Alzheimer's. So donepezil is going to be important when it comes to treating Alzheimer's disease. What about this one? Flaccid paralysis, poor feeding, constipation in a young baby that lives on a beehive farm. I gave you a hint there. What do you think is the best answer here? Go ahead and type it into the chat. Excellent. If you're saying botulism, you're absolutely correct. And this is inhibition. I think that this is very high yield of presynaptic snare proteins. Remember, the snare proteins are the ones that help you fuse the acetylcholine to the presynaptic receptor. Now, the infants with honey are going to ingest the spores, whereas if you are going to see an adult who gets botulism and it's related to canned foods, that's going to be preformed toxin. So the mechanisms are slightly different. You can also get botulism from a wound. And so let's say a patient is going to be an IV drug abuser, or maybe this is going to be a very, unfortunate surgery complication. Typically, you're going to see this about 10 days post the initial injury. Management, when it comes to your botulism intoxication, remember that these patients are going to have or be at increased risk for airway compromise. And you also want to provide equine anti-botulism toxin. And remember that that just kind of binds up the toxin, but it has no real effect on the acetylcholine binding at the receptor itself. What is going to inhibit snare proteins at the presynaptic receptors, but in particular, the neurons that are supposed to release glycine and GABA? Well, if you are going to inhibit inhibitory neurons, that's a double negative, you're going to get a very activated state, i.e., you are going to be thinking about tetanus, and in particular, the phenomena of the trismus and the opsotonos, which is the back arching. Remember that tetanus toxin is going to be the key virulence agent, and that's from the Clostridia species. And Clostridia is going to be a gram-positive, spore-forming, obligate anaerobe. Prevention is going to be Tdap. One of the questions that always comes up is when do you give immunoglobulin with the Tdap? And what's high yield for us to know is that you only give the Tdap plus immunoglobulin when you are dealing with a dirty wound and unknown or incomplete vaccination status of tetanus. So Tdap plus immunoglobulin during dirty wound and unknown vaccination status. All right, let's go ahead and go through this question. A middle-aged left-handed man presents with hyperacute difficulty speaking and right-sided weakness. After detailed history and physical exam, what is going to be the next best step? Well, a focal neurological deficit. What do you want to do? Well, you want to get a non-contrast head CT. And I think that that is exceedingly high yield. That non-contrast head CT is the first step in management when you see a focal neurological deficit. All right, let's go through this. He has a history of left atrial enlargement, secondary to left ventricular hypertrophy, and chronic hypertension. Exam shows marked motor and sensory weakness in both the left arm and the right leg. Oh my gosh, that doesn't follow a homunculus. What is the likely mechanism going on here? Well, whenever you are going to see atrial pathologies, you want to be thinking about the increased risk for arrhythmias. And in particular, you're going to be thinking about AFib, and AFib is going to be a hypercoagulable state because you have stasis and you can get a thrombus, and this can embolize to the brain. So a thromboembolic phenomena is what we're dealing with here, and this is going to be particularly known as a cardioembolic stroke. What's high yield for us to recognize is that embolic strokes are not going to follow the homunculus pattern. As you can see, the homunculus pattern and that whole concept of vascular distribution is going to not be the case in a cardioembolic stroke because you have multiple different vascular territories as the small thrombi are going to go through the cerebral vasculature. Management here is let's go ahead and see the clot on echo, try to work with neurointerventional radiology and get an embolectomy, and consider anticoagulation with heparin. So this brings me to a big management schema related to stroke. Now, stroke, the two kind of big distinct ways to think about stroke is hemorrhagic versus ischemic. Now, hemorrhagic strokes, that then is going to go into the thought processes of epidural, subarachnoid, subdural, and lobar, which is going to be associated with amyloid. Remember, epidural, you're going to have a lens-shaped lesion, usually due to trauma to the pterion. Subarachnoid could be due to arteriovenous malformation or Barré aneurysms. Subdural, this is going to be associated with shearing injury in patients who have brain atrophy, like dementia, for example. It can also be something seen along with retinal hemorrhages in non-accidental trauma. And then we said lobar hemorrhages are going to be in very elderly patients with cerebral amyloid. Ischemic strokes is what we are going to be focusing the next few minutes on, and that has different distinctions. Number one is going to be thrombotic. This can be of large vessels in the circle of Willis, like anterior cerebral artery, middle cerebral artery. It can be also due to small lenticulostriate vessels or lacunar vessels that are going to basically perfuse the deep brain. We talked about thromboembolic phenomena in our last question related to AFib, and that's why we do the CHADS VAS score to understand anticoagulation, so then we can prevent downstream complications like thromboembolic ischemic strokes. And then we also think about global ischemia, and this is where you have either hypotension or cardiac arrest, and you get this watershed infarct. And watershed infarct is going to be right at the border of something like the posterior cerebral artery and the middle cerebral artery. Whenever you're thinking about stroke, you should also be thinking about your workup or approach for altered mental status. Again, you're going to be getting airway breathing and circulation in your mind. I have to say that because I'm an intensivist. Labs that you're going to draw, electrolytes, tox screens, as well as ammonia. Ammonia can cause altered mental status. That's high yield for you to know. And then CT scan, you want to get before the LP because if there's any signs of increased ICP, you may hold on the LP. All right, so let's go into ischemic stroke. Again, these patients present with focal neurological deficits in general. And what an ischemic stroke is related to is a blockage of a cerebral vessel due to plaque rupture. And this plaque rupture is usually due to atherosclerosis. So in your test question, you want to pay attention to the past medical history: hypertension, dyslipidemia, poorly controlled diabetes. Whenever you are going to have blockage of the blood vessels, that can cause neuronal ischemia and cell death. And eventually, what can happen is you can get liquefactive necrosis of the brain tissue. Remember from step one, Lan, that the brain undergoes liquefactive necrosis, especially when there is going to be a cessation of blood flow. Now, what's high yield for us to know is that this acute blockage of the cerebral vessel can lead to a focal neurological deficit. Hypertension is the key risk factor for ischemic stroke. I think that that is a very highly tested point, that hypertension is a risk factor for ischemic stroke. And remember, once you have an ischemic stroke or even a hemorrhagic stroke, you're going to see a very high blood pressure, and that's just to maintain cerebral perfusion pressure. Remember that ischemic stroke, unlike hemorrhagic stroke, ischemic stroke are going to have a negative CT scan. Now, speaking of that, if you are going to be ruling out a hemorrhagic stroke, you're going to be going down the treatment route of an ischemic stroke. And that is going to be providing antiplatelet therapy with aspirin and or clopidogrel. You're going to also be considering thrombolytic therapy, especially, and this is key here, if the patient is going to be within 3 to 4.5 hours from symptom onset. And that's different. I mean, just to drop a little knowledge bomb here, percutaneous coronary intervention for a myocardial infarction, that's door to balloon in 90 minutes. Here, it's going to be 3 to 4.5 hours from symptom onset. And that's key for us to know, especially when the patient wakes up in the morning. Well, you don't even know when those symptoms started while the patient was sleeping. What's also high yield for us to know, and we're going to be talking about this in the next slide, are what are the contraindications to thrombolytic therapy? Just so that you guys are active and engaged. Name one contraindication to thrombolytic or TPA therapy. What is a one contraindication? Yeah, refractory, high blood pressure, any bleeding. Absolutely. Very good. Now, MRI and MRA is going to be a little bit more specific. You want to get that after your CT scan, and that's extremely high yield. You know, UWorld also tests that when it comes to a child who is going to have stroke-like symptoms, get them into the MRI scanner, look at the blood vessels as well. All right, so contraindications to thrombolytic therapy. This is going to be very high yield for us to know. Number one is if you have a hemorrhagic infarct as defined by a non-contrast head CT, no, you do not give thrombolytics in this situation because of risk of progressive hemorrhage. If you have a past medical history of a stroke in the past 3 months, any sort of history of intracranial hemorrhage or arteriovenous malformation, or a recent brain surgery. Again, the big picture here is that these patients are not going to be good candidates for TPA therapy because they are going to be at increased risk for bleeding. If you're going to have very, very elevated blood pressure, greater than 185/110, these patients are at high risk for hemorrhagic transformation. From an ischemic stroke, you give TPA and bam, now they are in the hemorrhagic stroke category. And then you want to think about the labs in the vignette. And you want to assess, hey, if they are thrombocytopenic, very hypoglycemic, or let's say in their med list, you see warfarin and their last INR is going to be very elevated. These are, again, going to be patients who are at increased risk of bleeding, and you don't want to give TPA in this situation. One of the basic science integrations that I want to go into now is this mantra that I love to say when I tutor students, and I say, know the physics behind the physical exam. And what does that mean? Well, when you see a bruit, for example, and this is going to be when you're assessing the carotids, what does a bruit represent? You can even see a bruit when you're talking about renal artery stenosis or a AAA. Bruit represents turbulence, and that's high yield for us to know. So the pathology that I'm going into right now is carotid artery stenosis. And there are a couple key management nuances that you have to know with carotid artery stenosis, because again, carotid artery stenosis is going to be due to a lot of atherosclerosis. And if this atherosclerotic plaque is going to occlude the carotid or embolize somewhere, you can actually get a stroke. So you can just say, hey, carotid artery stenosis is going to be a precursor lesion to a stroke. So let's say the patient has greater than 70% occlusion of the carotid artery and is going to be symptomatic. You may want to consider carotid endarterectomy. And in my surgery shelf review, I'm going to go into this in a little bit more detail. If the patient is going to have carotid artery stenosis, you're going to do a trifecta of making sure you have primary prevention with aspirin. Then you're going to be providing lipid control with a statin. And then you also want to control blood pressure. Again, hypertension is the key risk factor related to ischemic strokes. If the patient has significant carotid artery stenosis, greater than 80 to 99% on your duplex carotid scan, and the patient is asymptomatic, let's say that they say it's incidentally found at a health fair, well, just go to carotid endarterectomy and take out some of that plaque. And then finally, if the patient is going to have less than 50% of occlusion with or without symptoms, less than 50% occlusion, you are not going to do CEA. And that's a very important step for you to keep in mind, because then you transition into the management scheme of, okay, well, let me make sure that their blood pressure is well controlled, their lipids are well controlled, and maybe even consider putting them on aspirin. All right, so we are diving deep into stroke land. And when it comes to stroke, remember the next best step in management: airway, breathing, circulation, and then obtain a non-contrast head CT. With an ischemic stroke and hemorrhagic stroke, we've gone through some key distinctions. In an ischemic stroke, you want to avoid antihypertensives. Unless your blood pressure is crazy high, like greater than 185 over 110, you want to avoid antihypertensives because the patient is having relatively normal cerebral autoregulation. After an ischemic stroke, your blood pressure is going to be very elevated in order for you to maintain cerebral perfusion pressure. With an ischemic stroke, you want to also get an echo as well as a angio head and neck. Why do you want to get an echo? To make sure that you don't have a left atrial thrombus. And then we talked about the consideration of TPA therapy. Hemorrhagic stroke, it's all going to be related to elevated intracranial pressure management. And the USMLE loves for you to know what are the steps you can take for elevated ICP management. I'm going to go ahead and give you a very advanced management question. Besides 3% hypertonic saline, what else can you do for ICP management? Go ahead and type that into the chat. Okay, many people are saying mannitol. Yes, okay. Besides 3% hypertonic saline, you can elevate the head of the bed. You can also hyperventilate the patient. Very good. If the patient had a C-collar on, you may want to decrease any tension or tightness at that C-collar. You may want to even call neurosurgery to do a EVD placement or just do a craniectomy. Very good. All right. This is going to be a neuroanatomy review. This slide and the next slide, very busy, but we're going to go through it. Let's go ahead and just take a deep breath at home. Here we go. All right, let's go through this. We're going to be going through the circle of Willis because this anatomy is high yield for us to know, because then after we know this, we can localize strokes. The vertebral artery is going to come from the back side of your body, and the vertebral artery is going to give off two branches, which is posterior inferior cerebellar artery, as well as the anterior spinal artery. The vertebral comes up and makes the basilar. Name one of the branches that come off of the basilar that perfuses the cerebellum. Go ahead and type that into the chat. Wonderful. If you're saying pontine vessels, that's fine, but ICA is going to come off of the basilar. So I like to think of this mnemonic: pica from the vertebral, ica from the basal. The terminal branch that is going to perfuse the cerebellum that comes off of the basilar is going to be the superior cerebellar artery. And you're also going to have the posterior cerebral artery that is going to be one of the terminal branches after the basilar. Remember, the posterior cerebral artery is going to be the back portion of the circle of Willis. How is the posterior circulation attached to the middle cerebral and anterior cerebral? Well, that's via the posterior communicating artery. Remember that the middle cerebral is going to come off of the internal carotid artery. The anterior cerebral kind of goes forward and then loops all the way back. And understand that there is the ACOM, which is the anterior communicating artery. And this is where Barré aneurysms can form because there's not a strong media there. Now, off the MCA, I do want to also pay respects to these small lacunar arteries or ventriculostriate arteries that are going to perfuse the deep portions of the brain, like the basal ganglia, internal capsule, and subcortical regions. So when a patient is going to have a focal neurological deficit after the non-contrast head CT and you're going down the ischemic route, what are you going to do? Pay attention to the physical exam, because this is the three-step approach to localize that stroke. You're going to say, hey, the brain is going to be contralateral. In large vessel strokes, you're going to have sensory and motor deficits on your physical exam. And you want to understand the homunculus. This approach is going to help for ACA and MCA strokes in particular. So the foot, trunk, that's all going to be ACA. And the face and upper extremities, that's going to be the MCA. Remember that MCA on the dominant hemisphere, typically that is going to be the left hemisphere. That is going to also have your Wernicke and Broca, i.e. language centers. And then in your non-dominant MCA, you're going to have the parietal centers. And these parietal centers, if damaged with a non-dominant MCA stroke or a right MCA stroke, you can have contralateral hemi-neglect syndrome. All right. Well, I'm going to go ahead and go through this question. A 58-year-old male with history of hypertension and smoking is brought to the emergency department due to acute sudden onset difficulty speaking that began 2 hours ago. Pause. Focal neurological deficit. What are you guys thinking of? Go ahead and type that into the chat. One word. Focal neurological deficit. Beep. Exactly. Stroke, stroke, stroke. Very good. He also is noted to have right-sided weakness in the upper extremity. So right side weakness, maybe we're thinking about the left side of the brain. Sensory exam shows decreased sensation to pinprick in the upper extremity. Which of the following vascular distributions is most likely affected in this patient? So this is a patient who has right-sided hemisensory and motor loss in the right upper extremity. Go ahead and type your answer into the chat box. Many people are saying MCA. Good. Well, with the difficulty speaking, you may be actually thinking about a Broca aphasia. And so the best answer may be left MCA. Okay. Now, you're obviously going to confirm with a MRI, but as you note, the 3 steps: contralateral for the large vessel strokes, both sensory and motor. And that's going to be very important, guys, because that's what differentiates it from the lacunar strokes. Lacunar strokes are pure motor, pure sensory. And then finally, recognizing that the dominant centers are going to be the left side of the brain usually, and that's the Broca. And remember, the Broca area is going to be the posterior frontal gyrus. All right. What we are going to be doing now is something very high yield. Hang with me. This is going to be a very busy slide, but what I'm going to do is I'm going to be giving you the key vignette features for each of these strokes. Key vignette features for each of these strokes. Let's go through it. Anterior spinal artery stroke. What you're going to be thinking of, and this is interesting how the specific font did not go through. That's okay. We don't need to worry about Morse code. So this is what we're going to do. We're going to go ahead and go on my PowerPoint. So new share, desktop 1. Can everybody see my screen? Yes, no, maybe so. Excellent. Very good. This is all about pivoting, right? That's what entrepreneurship is all about. All right, here we go. Anterior spinal artery. Remember that the anterior spinal artery, that's going to perfuse the middle portion of your spinal cord, and the hypoglossal nucleus is actually going to be right at that middle portion. So in anterior spinal artery strokes, you're going to get tongue deviation towards the side of the lesion, as well as issues with the medial longitudinal fasciculus, and that's where you get contralateral loss of proprioception. Now, vertebral artery insufficiency is tested on the USMLE in 2 ways. Number 1, they can give you a vertebral artery dissection. This is going to be a oropharyngeal trauma, and the patient is going to have cerebellar signs, nystagmus, ataxia. You can present like a pica stroke, which we're going to be talking about in just a sec. Subclavian steal syndrome, this is where you're going to get acute narrowing of the aorta, and subsequently, you're going to have a gradient that reverses flow in the vertebral artery. So if you have reversal of flow in the vertebral artery, you're going to get signs of ischemia. You're going to also have, because of the kink of the subclavian artery, a blood pressure difference between your upper extremities. You could get upper extremity pain because of the ischemia, and then cerebellar signs. So as you can see, the vertebral artery, any pathology to that, you're going to see a lot of cerebellar symptoms. Now, ICA and pica strokes really confused me when I was studying. And the way I like to categorize ICA and pica strokes is that both of these strokes have ipsilateral face and contralateral body loss of pain and temperature. I want to re-emphasize that. If you see ipsi face, contra body, loss of pain and temperature, you're dealing with ICA or pica stroke. Now, how do you tell the difference? Well, ICA stroke are going to have facial droop, loss of corneal reflex, because again, the efferent arc of the corneal reflex is going to be cranial nerve 7. And because you don't have the chorda tympani, they can also put loss of taste in the anterior 2/3 of the tongue. Pica strokes are going to have deficits in cranial nerve 9 and 10, so you're going to have issues with the uvula, hoarseness, and dysphagia. Mnemonic here, when you see a facial droop, ICA is poop. Mnemonic here, don't pick a horse that cannot swallow. Understand the fact that both of them are going to have loss of pain and temperature, ipsi face, contra body, plus cerebellar signs. So don't get confused with this. Lean in and categorize the symptoms. A basilar artery stroke, especially involving the paramedian pontine vessels, for example, is going to be a patient who's in the ICU who had very bad hypotension and now is not able to move the entire body, but is only able to communicate with the eyes. A superior cerebellar artery stroke, I haven't seen this tested too much. However, I do want to just review that any cerebellar symptom is going to be categorized or is going to manifest, as ataxia, dizziness, dysmetria, where the patient is going to have an inability to have those fine movement control with the finger to nose testing. They can have that intention tremor. They can also have dysdiadokinesia. So if you want to go ahead and go like this to yourself, that is how you test that rapid coordinated movement. Posterior cerebral artery strokes, the key thing for us to understand is that the posterior cerebral artery perfuses the occipital lobe, which is your primary visual cortex. And so what these patients have is a contralateral hemisensory loss. Again, this is going to be related to the fact that PCA is a large vessel stroke, but then they're going to have issues with vision. What textbooks and all of your question banks talk about is macular sparing. Now, what the hell does that mean? How do they put it in a vignette? Well, they say central vision is preserved. That's your macula. Macular vision or central vision is preserved. However, the visual fields, those peripheral visual fields, are affected on the same side. And that's called a homonymous hemianopsia with macular sparing. What about that linker vessel, which is the posterior communicating artery? Well, what's unique is that the posterior communicating artery can also have a very aneurysmal dilation, and it can compress cranial nerve 3, which is where my arrow is. My arrow is going to be right in between the superior cerebellar artery and posterior cerebral artery. Well, if you get a posterior communicating or PCOM aneurysm, you can get compression of cranial nerve number 3. And remember that if you get minor compression, just the outside, you lose parasympathetics. And so the patient may have ipsilateral mydriasis. Or if you get progressive aneurysmal compression, you can also compress the motor fibers. And that's where you get the down and out people. And that's related to the antagonism or the unopposed lateral rectus and superior oblique, which are not cranial nerve 3. They are going to be 6 for lateral rectus and 4 for superior oblique. We talked about ACA and MCA strokes. ACA and MCA strokes, they are going to have both motor and sensory loss, usually in the contralateral distribution. And how do you tell the difference? Know your homunculus. ACA is trunk and lower extremities. MCA is going to be the face and upper extremities, and understand the hemi-neglect for the non-dominant, which is usually the right, and then the dominant lobe MCA infarctions usually are going to be speech. We talked about how there are small branch vessels that come off of the MCA. Those are the lacunar or lenticulostriae arteries. These supply the deep brain. In particular, you have to understand that deep brain structures are your basal ganglia, the internal capsule, which is going to be a highly myelinated set of relay fibers as you are going to go from the body, brainstem, and up to the primary motor or sensory cortex, and then the thalamus, which again is that relay center as you get the information to the cortex. Whenever you have lacunar or lenticulostriae arteries, let's go ahead and word cloud some of the things that are tested on USMLE questions. Number one, they are going to put that the patient has pure motor or pure sensory, i.e., look at the physical exam. If they say that there is weakness, but sensation is still present, pure motor. What's also high yield for us to know is that the key risk factor for lacunar strokes is hypertension, and poorly controlled hypertension can cause you to have a extravasation of proteinaceous rich kind of fluid in those deep vessels, and that is going to form the lakes. And on histology, you get lipohyalinosis in that region. Anterior communicating artery. Remember that this is going to be a region where you primarily are going to have Barré aneurysms, as you are going to have the ACA and the branch into the anterior communicating. You lose the media, so you can get aneurysmal dilation and get Barré aneurysms. Remember, and this is so high yield, guys, patients with Marfan syndrome, Ehlers-Danlos, and autosomal dominant polycystic kidney disease, they are prone to having ACOM Barré aneurysms, anterior communicating artery Barré aneurysms. And when they pop, goes the weasel. When they pop, they can cause subarachnoid hemorrhage. Painful, worst headache of my life, thunderclap headache. That was a lot. I hope that that integration helped. Took me a while to make that slide, but it's all good. Anything for the HyGuru fam. All right. We are almost done. I want to continue on with the review. Are you guys doing okay, staying active and engaged? Excellent. Princess, Seth. Excellent. Joy, Supriya. Thank you, guys. Hugs all around. Let's go ahead and keep going with our review. An elderly male with history of smoking and hypertension presents with sudden onset vertigo and nausea. He reports difficulty swallowing and has left face numbness. On exam, he has loss of pain sensation on the right upper and lower extremity, as well as a decreased gag reflex. What is the likely diagnosis here? Go ahead and type that into the chat. Very good. So you activated the illness script, the fact that we have cerebellar symptoms, and we are going to have ipsy face, contra body, loss of pain and temperature. And then we're combining it with don't pick a horse that can't swallow, i.e. you are going to have hoarseness or any sort of 9 and 10 symptoms. So the answer is going to be a left pica stroke. This is where you're going to have lateral medullary syndrome, where you get damage to the vestibular nuclei, the spinal trigeminal nucleus, the inferior cerebellar peduncle. That's why you're going to get this vertigo, nausea kind of sensation. The nucleus ambiguous, which is going to have your 9 and 10 nuclei, as well as spinothalamic. And again, this is going to be the reason why you have the loss of pain and temperature. Biggest risk factor for stroke is hypertension. So I want to go through the key vignettes related to hypertension for your USMLE. All right. Aortic dissection, another key pathology that you want to attach the risk factor of hypertension with. Atherosclerosis, understand that that is linked with hypertension. AFib, linked with hypertension, because chronic hypertension can cause you to have left atrial dilation as you get concentric hypertrophy of the left ventricle. Congestive heart failure, you can get dilation of the LA that can lead to atrial fibrillation. Remember, hypertension is one of the risk factors for congestive heart failure. Subarachnoid hemorrhage, again, if you have vascular strain due to hypertension, that's no bueno. You can have a popping of your aneurysmal dilations or AVMs. And then finally, we talked about stroke, particularly ischemic strokes related to hypertension. All right, 3 vignettes on this slide, 2 vignettes on the other. Let's go ahead and integrate some key ischemic neurological disease. All right, what if you have a patient who comes in with dizziness, facial asymmetry, arm weakness, but it only lasts for 1 hour? What do you think is the best answer here? What's the diagnosis? Focal neurological deficit stroke, but this is going to be a transient stroke, i.e. a TIA, transient ischemic attack. Now, the management here is first, make sure that the patient is not hypoglycemic, and key, very high yield for you to know, get an EKG. Why? You want to rule out AFib. I can't stress this enough. Reduce the subsequent events by controlling atherosclerotic and thrombotic risk factors. So you're going to put them on aspirin. If they're already on aspirin, add clopidogrel. In prior literature, dipyridamole was a push, but now I think I see more and more clopidogrel. If the patient is going to have a carotid ultrasound during this TIA and they have greater than 70% stenosis, you may want to go for carotid endarterectomy. Lipid management with statin and blood pressure management with antihypertensives is going to be key. All right, next vignette. Ipsilateral headache, Horner syndrome, neck pain, and transient painless vision loss after a posterior oropharynx trauma. Let's say, for example, a pencil got shoved up at the roof of the mouth. Excellent. This ipsilateral headache and loss of sympathetics with the ptosis, meiosis, and hydrosis, and the amaurosis fugax, which is going to be a ischemic symptom, that is going to be related to a carotid artery or cervical artery dissection. And as you can see, there is going to be a thrombus that is going to be in the intimal flap that is going to then cause your blood vessel to be occluded. The key here is to get the duplex ultrasound of the neck. You may also want to get an angiogram. And then because there's a thrombus, consider heparin therapy plus or minus aspirin. Okay, how about this one? Ipsilateral Bell's palsy, loss of pain and temperature in one side of the face, and contralateral body. So ipsy face, contra body should activate ICA pica. And this one is Facial droop, ICA is pooped. Excellent. And this is lateral pontine syndrome with the ICA stroke. All right. I want you guys to continue to stay active and engaged. Let's go ahead and go through this slide. Subacute progressive aphasia, falls, and a vertical gaze palsy in a patient with Parkinsonian-like features. This is a very tough question. I saw this on UWorld, so I wanted to also put this in. This is going to be progressive supranuclear palsy. So this is under the category of Parkinson plus syndrome. And in this pathology, you're going to have Parkinsonian-like symptoms. However, it's not true Parkinsonism. True Parkinsonism is going to have a more chronic tempo, and you are going to have a pill rolling tremor. So if you see a patient with Parkinsonianism symptoms, and in this case, vertical gaze palsy, that is more rapid in tempo, and there's no tremor at rest, you need to be thinking about progressive supranuclear palsy. And another thing that is going to stratify this from true Parkinsonianism is the fact that you have a poor response to levodopa. All right, next one. Subacute recurrent exertional back pain, worse when walking downhill in a previously healthy, obese, middle-aged male with normal pulses on physical exam. What is going to be the likely diagnosis here? Excellent. If you're saying lumbar spinal stenosis, you are absolutely correct. Remember that this is going to be a narrowing of the spinal canal. It could be due to wear and tear and related to obesity. What's high yield for us to know is that if they say normal pulses on physical exam of the lower extremities, that rules out vascular claudication due to peripheral artery disease and atherosclerosis. This is primarily going to be lumbar spinal stenosis, and the pain is going to be better when leaning forward, and that is going to be related to the shopping cart sign. Treatment is going to be reduce the pain with NSAIDs, physical therapy, and you may need to do laminectomy, especially if you are going to have a very narrow spinal canal. All right, how about this one? Recurrent neck pain, radicular arm pain, which then progresses to urinary frequency and upper motor neuron signs in the lower extremities. So in this chronic type of tempo, this is going to be cervical spinal stenosis. Now, cervical spinal stenosis, because the cervical nerves are going to have a lot of information from the whole body, this cervical spinal stenosis is going to be, number one, defined as a narrowing of the cervical canal leading to cord compression, and you will get signs of myelopathy below the level of compression. And in particular, you may get flaccid paralysis at the level of the lesion. However, if you have damage to the corticospinal tract fibers going up via the upper portion of the spinal cord into the brainstem, you're going to be getting upper motor neuron signs in the lower extremities, as well as issues with bowel or bladder. And so this is very important for us to know as a, kind of severe form of spinal cord injury. Now, MRI of the head and neck is going to isolate this lesion because it's in the cervical spinal cord, and this can show spondylosis. And what spondylosis is it is a degenerative spine that is causing narrowing of the spinal canal. That's the definition of spondylosis. You can see spondylosis in lumbar spinal stenosis as well as in cervical spinal stenosis. Again, you're just getting loss of bone, and that is going to make the spinal canal much more small, and thus the spinal cord is going to get compressed. Now, speaking of spinal cord symptoms, what we want to incorporate is the acute spinal cord syndromes. And what are the acute spinal cord syndromes? Cauda equina syndrome and conus medullaris. And this is key on the USMLE. Now, Cauda equina syndrome, you want to understand that usually this is going to be due to the horse's tail, which is going to be your peripheral nerves that are going to be emanating from the bottom portion of the spinal cord. As a result, if you have Cauda-Equina syndrome, you're going to have unilateral radicular pain, asymmetric lower motor neuron findings, hyporeflexia, again, lower motor neuron finding, and saddle anesthesia of the perineum. The etiologies are going to be disc herniation and or epidural abscess. What's high yield for us to know is if you see Cauda-Equina syndrome, number one, bowel or bladder stuff is going to be a late finding. And you want to look for areas of compression. So get a MRI of the back, especially if the social history shows IV drug abuse in the test question, indicative of an epidural abscess that is compressing the peripheral nerves emanating from the bottom portion of the spinal cord, i.e. the Cauda-Equina nerves. Now, conus medullaris syndrome, this is going to be true disease or pathology of the terminal portion of the spinal cord. These patients get symmetric motor weakness. They get hyperreflexia, again, an upper motor neuron sign, and they get early onset bowel and bladder dysfunction. One high yield thing for us to just continue to keep in mind with these acute pathologies is we need to get urgent MRI and wake your neurosurgeon up at 2 a.m. with an emergent consult. All right, let's go ahead. Couple more questions, and then we will be done. Let's go ahead and go through this multiple choice question. A 6-year-old male presents to the intensive care unit after diagnosis of subarachnoid hemorrhage. 1 hour after admission, his vital signs are notable for hypertension, low heart rate, and respiratory rate of 12. He has a right pupil minimally reactive and 4 millimeters in diameter. His left pupil is noted to be just fine. Given normal cerebral autoregulation, which of the following interventions may reduce elevated ICP in this patient? A, hypoventilation. B, don't change the respirations. C, increase blood pressure by stimulating alpha receptors. Or D, hyperventilation. So please recognize that a brain bleed can increase ICP and you get Cushing's triad. And what you want to do is recognize that if you hyperventilate a patient, increased respiratory rate, you then blow down CO2 and you get cerebral vasoconstriction. And that cerebral vasoconstriction is going to lower your intracranial pressure. Very high yield. All right. So ICP management, you get neuronal swelling, and that neuronal swelling actually causes a high sympathetic response. And that's why patients with increased ICP are going to have high blood pressure to maintain cerebral perfusion pressure. As you have increased stretch at the carotid artery, you're going to get baroreceptor activation, and that can actually cause you to have bradycardia. And if you are going to have progressive neuronal swelling, that can compress on your brainstem centers, and that's why you get the irregular respiration. So what I just described was Cushing's triad. Remember that baroreceptor activation can cause you to have bradycardia. In the setting of hypertension and bradycardia, always think about high ICP. Combine that with papilledema that indicates that there is high ICP or compression of your optic nerve. Management, 3% hypertonic saline, and consider hyperventilation along with making sure the head of the bed is up, and then consider external ventricular drain placement plus or minus craniectomy. A 35-year-old female presents with difficulty walking and urinary urgency. She has had an emergency department visit in the past with eye pain and blurry vision. Examination shows increased muscle tone in the lower extremities and hyperreflexia. MRI shows periventricular T2 hyperintense lesions. A lumbar puncture is performed. Which of the following findings would most likely be found in this patient? Go ahead and take some time to isolate what you think the diagnosis is and what is going to be the CSF finding. And if you're continuing to watch right now, please stay active and engaged. It's so important for you to continue to be extremely, extremely focused throughout this session. All right, excellent. If you're saying oligoclonal banding, you are absolutely correct. This is going to be the diagnosis of MS. MS, recurrent, non-specific focal neurological deficits in a female. High yield for us to know, recurrent, non-specific focal neurological deficits separated by time and space in a young female. All right, excellent. Just real quick, other answer choices: decreased glucose and elevation in polymorphic neutrophil leukocytosis. That's for bacterial meningitis. Elevated protein with normal cell count. What do you guys think is going to be the one answer choice B that I'm highlighting in green? What is that pathology, everybody? Good. Very good. Guillain-Barré syndrome. And then elevated opening pressure, you're going to be thinking about, with elevated opening pressure, you're going to be thinking about any sort of, bacterial meningitis. But in particular, I think of the HIV patient who is going to have coccidiomycosis. Coccidiomycosis has not coccidiomycosis, cryptococcus, my bad, cryptococcus meningitis. Cryptococcus meningitis actually has a very elevated opening pressure, and that's very important for you to know for step 2 and 3. All right, so let's just go through a quick basic science integration. Remember, MS, you're going to have T cells that are really going to attack your oligodendrocytes, and that's so high yield for you to know. Remember that the T cells can interact with the B cells, and what you end up getting is antibodies and cytokines released that then are going to attack and demyelinate many of your CNS neurons, and that's what the periventricular plaques represent. Next best step in diagnosis, MRI of the brain. You can see the periventricular plaques. Remember, you can also see optic neuritis when you're getting your MRI of the brain. And anybody who has bilateral trigeminal neuralgia, if you have bilateral trigeminal neuralgia, you need to be thinking or screening of multiple sclerosis. Now, lumbar puncture is going to also be one of the key management steps. You're going to be thinking about IgG oligoclonal banding. The risk factors related to MS is going to be young female age, but also vitamin D deficiency, HLA-DRP1, as well as smoking. Key presentations here is going to be bowel and bladder incontinence. Remember that this is going to be urge incontinence and intranuclear ophthalmoplegia. And remember, intranuclear ophthalmoplegia presents as failure to adduct the affected eye on contralateral gaze. So if you can't get that eye to the midline, you're going to be thinking of the demyelination of your MLF, medial longitudinal fasciculus. Okay. All right. Go ahead and take some time, read this vignette, and go ahead and put into the chat, what's the next best step in treatment? All right. Many of you are categorizing this as an MS flare. She's noted to have an afferent pupillary light defect, indicating that the optic nerve is going to be inflamed. This is an optic neuritis. And for a flare, you want to, yes, get an MRI, but the next best step in treatment is IV methylprednisolone, high-dose steroids. And then if that doesn't work, take those bad autoantibodies out. Very high yield for you to know. All right. The last thing we are going to be talking about here today is seizures. Let's go ahead and go through this question. Let's say on your USMLE, you have a patient who comes in with subacute decline in grades with preserved developmental milestones in a school-age child who presents with recurrent staring spells and eye blinking. What is the likely diagnosis here? Very good. Excellent. Absence seizures, these staring spells. That's super important. What is the next best step in management? This is the only time really where the USMLE actually asks you for a specific anti-epileptic, and that is going to be ethosuximide, absolutely. But the next best step in management is confirm it. You have to confirm it. Get an EEG. And the EEG is going to be showing you this 3 Hertz spike and wave pattern. You don't need to be an epileptologist or read EEGs for step 2 CK, but understand that 3 Hertz spike and wave should activate the illness script of absence seizures, just like hypsarrhythmia, which is chaotic waves, is going to activate the illness script of what pathology? Of your infantile spasms, okay? And so what is high yield for us to know is that ethosuximide is going to inhibit T-type calcium channels. Other considerations, you could be thinking about valproic acid, Keppra, but key historic treatment is ethosuximide. And again, the USMLE doesn't go for gray zone ever. So whenever I think about seizures on the USMLE, this is going to be the categories I think of. Febrile seizures, especially if it's a 2 to 5-year-old baby who is going to have rhinorrhea on exam, and then they have a seizure and then they're going to be fine. That's high yield for you to know, febrile seizure. You're going to be thinking about meningitis and encephalitis as one of the key distinctions, especially if they're going to have neck stiffness. Metabolic causes, such as hypoglycemia or hypo or hypernatremia. You're going to be thinking about vascular causes as well, and then structural causes, i.e. a new presentation of a brain tumor. That's high yield. So these are all going to be key pathophysiologic schemas. All right. So when it comes to seizures, you want to understand the vocabulary of how to convey what kind of seizure the patient has. One of the ways to convey what kind of seizure the patient has is really differentiating focal versus diffuse. This is where the electrical activity and the chaotic discharge is going to start from. Is it a focal part of the brain, or is it diffuse chaotic neuronal activity? Now, focal is going to indicate that one part of the brain, like the temporal lobe, for example, is going to be messed up. And so, as a result, these patients can have either awareness or they can have impaired awareness. And you can stratify, okay, this is going to be a focal seizure where the patient is still aware. This used to be known as a partial seizure, for example. Generalized seizures are going to have the electrical activity be across the whole brain, i.e. across the corpus callosum. This is going to be related to absence seizures, myoclonic seizures, tonic-clonic seizures, as well as drop seizures. Absence seizures, think about the staring spells. Myoclonic seizures, this is going to be in your vignette, a teenager who is going to have jerks of the upper extremities. Maybe they're going to have dropping of the pencil all the time. Tonic-clonic seizures, this typically has impaired consciousness. And then drop seizures, these are known as atonic seizures. And the differential here is actually going to be either syncope or is going to be a breath holding spell in a toddler. Now, in terms of pharmacotherapy, again, pharmacology is going to reverse the pathophysiology. You're going to be thinking about sodium channel blockers like carbamazepine, lamotrigine, phenytoin. Remember that carbamazepine is going to be the treatment for trigeminal neuralgia, and think about also SIADH as one of the risk factors. Lamotrigine can cause you to have Stevens-Johnson syndrome along with phenytoin. Remember that phenytoin is also going to be a teratogen. Levetiracetam is going to inhibit the synaptic vesicle 2A protein. This is commonly known as Keppra. We use Keppra for both focal and diffuse or generalized seizures. Absence seizures, think about ethosuximide. Myoclonic seizures, think about valproic acid as one of the key treatment modalities. And valproic acid inhibits many different ion channels, such as sodium, calcium, and GABA. Remember that valproic acid inhibits folate. That's high yield for you to know. And this is also going to be a teratogen. How do you tell the difference between breath holding spells and syncope as the cause of a patient fainting on your USMLE? Well, postictal state. Usually, if they say no tongue biting or the patient is not confused afterwards and they're back to their baseline very quickly after the sudden episode, you're dealing less with a seizure and more with a breath holding spell or just generalized syncope. And then you go through your differential of syncope: neurogenic, cardiogenic, vasovagal. Finally, let's say that the patient in your vignette just keeps seizing. Refractory generalized seizures, back-to-back seizures. You're going to be thinking of status epilepticus. This is something that I see in the pediatric ICU, and you're going to be thinking about your airway, breathing, circulation. Give GABA agents such as benzodiazepine. Load with anti-epileptic drugs. Get a bolus of anti-epileptic drugs in to stop the seizures. And once the patient is stable, get your diagnostics: a metabolic panel to rule out sodium and glucose disorders, a toxicology screen, a head CT, as well as EEG therapy. With that, I want to end our session today. I just want to say thank you from the bottom of my heart. I hope that this was a very helpful session. I want you to just stick around for 1 or 2 minutes. Please note that next weekend, we will be having a comprehensive surgery review. I do want to put into the chat box the link for you to sign up for this. I also have put in the curriculum, but let me go ahead and put this into the chat box right now. Go ahead and click on those links. They're also on HyGuru.com. I also have the PDF curriculum. My goal during the surgery review is to teach just like how I did today. The key to learning is integration. If you sign up for my pass-fail course, or for my, surgery shelf review, I will give you access to my Step 2 CK rapid review course. All of the things that you will get if you register for the Step 2 CK surgery review, all of the information is within the Zoom link. So carefully check it out. Again, I will post this right here. If you enjoyed this session, share it with a friend. My goal is to spread the message of HyGuru one student at a time. So here are different ways where you can connect with me and share your feedback. Even if you Google HyGuru Trustpilot and just write a quick review. What did you like about this session? Where are areas for me to improve? I'm always here to serve bright students like you. With that, I will end. Before you leave, type one thing you learned, and I will stick around for some questions. Thank you from the bottom of my heart for joining today and spending this last hour and a half with me.